Welcome to This Explainer. Today, we're taking a fascinating journey that seamlessly bridges ancient Ayurvedic surgical texts with the rigorous, high-stakes practices of modern operating rooms. We often think of modern medicine as being completely detached from the past, right? We kind of just assume that everything vital to patient care was invented in the last century. But as we're about to see, the true blueprints for today's life-saving procedures were actually drawn up thousands of years ago. By understanding these roots, we gain an entirely new appreciation for the precision of modern surgery. So get ready to look at the medical instruments and practices you thought you knew in a completely new light.
Just listen to this profound observation for a second. Yantra are instruments used to assist surgery by grasping, supporting, extracting, examining, and manipulating tissues. That definition comes directly from Acharya Sushruta, who is universally recognized as the father of surgery. What he's describing here are blunt surgical instruments, tools designed not for cutting, but for safely performing procedures, improving precision, and, crucially, reducing unnecessary tissue injury. It's a brilliant ancient concept that laid the absolute groundwork for the massive, highly specialized surgical setups we see today.
Section 1. The Surgeon's Arsenal. Ancient Tools, Modern Medicine. Okay, let's dive into exactly how those tools translate. The instruments surgeons rely on today are, in so many cases, brilliant, direct refinements of ancient designs. Sushruta classified yantras into major groups based on their mechanical function. Because, while technology changes, human anatomy definitely does not. Take the Sundansha yantra, described as a forceps-like instrument used for holding tissues. That translates directly to the modern tissue or artery forceps used to clamp bleeding vessels today. The Nadi yantra, which is tube-shaped, perfectly mirrors today's catheters and endoscopes for accessing hidden cavities. The rod-like shalaka is our modern probe for exploring wounds. And the cross-shaped swastika, that is exactly what orthopedic surgeons use today as bone-holding forceps to stabilize fractures. The continuity of human engineering here is just staggering.
20. I want you to take a moment and let that specific number sink in. That is the exact amount of shastras described by Sushruta. Now, while yantras are the blunt tools we just talked about, shastras are the sharp, precision-cutting instruments. They're used to incise, excise, puncture, and scrape tissues. Having 20 distinct designs mapped out meant that ancient surgeons weren't just hacking away. They had tailored, highly specific tools for delicate surgical needs, everything from draining abscesses to meticulously removing foreign bodies.
So, the crucial point here is the staggering, rigorous standard to which these ancient tools were held. An ideal shastra wasn't just any old piece of metal. It had to be strong, perfectly balanced in the hand, easy to sterilize, and completely rust-free, which, by the way, is an incredible metallurgical feat for the time. The ancient texts literally specified that a shastra should be sharp enough to easily slice through a human hair floating on water. I mean, no way, right? That is a level of microscopic precision that easily rivals modern manufacturing. It shows this profound understanding that dull tools cause unnecessary trauma, prolonged healing, and just generally worse outcomes for the patient.
But what happens if you're in an emergency and a perfect metallic shastra just isn't available? Enter Anushastra, the secondary cutting instruments. These were natural, everyday items ingeniously used as emergency substitutes. We're talking about a sharp bamboo splinter, a piece of glass, a crystal, or even a fingernail used to scrape tissue or extract a foreign body out in the field. Sure, they were less precise and carried a higher risk of infection, but they were cheap, readily available, and potentially life-saving in a pinch. Why this matters today is that it highlights the universal human ability to adapt. It reminds us that medicine, at its very core, is about using whatever's at your disposal to preserve life, even when standard technology completely fails. Section 2. When blood vessels fail. From tools to pathologies.
Let's bridge over from the surgical tools themselves to the actual vascular diseases that these very tools are designed to treat. First up, we need to understand venous thrombosis, which basically just means the formation of a blood clot inside a vein. We have to distinctly compare two conditions with vastly different stakes here. Superficial venous thrombosis, or SVT, occurs in the veins near the surface of the skin, usually presenting as a painful, warm, cord-like vein. It's uncomfortable for sure, but relatively mild. But deep venous thrombosis, DVT, occurs in the deep, major veins, like the femoral veins hidden deep inside the leg muscles. DVT is extremely serious. Why? Because a deep clot can break off, travel rapidly through the bloodstream, and lodge right in the lungs, causing a pulmonary embolism. That is an absolute, life-threatening emergency, which makes early clinical distinction vital.
Now, let's consider another highly common vascular issue that millions of people deal with: varicose veins. The mechanical failure here happens step by step. Normally, healthy valves inside our leg veins act like one-way doors, ensuring blood flows up against gravity toward the heart. But if a valve fails, often due to prolonged standing, pregnancy, or just basic genetics, we get venous reflux. Blood flows backward and begins to pool. The venous pressure dramatically increases, and the vein physically dilates to handle the volume. Over time, the vessel wall breaks down, becoming permanently elongated, bulging, and tortuous. Understanding this chain reaction explains exactly why simply treating the surface of the skin isn't enough. The underlying pressure system actually has to be surgically corrected.
If chronic venous issues, like those varicose veins we just talked about, are left untreated, they can eventually lead to tissue breakdown, causing a venous ulcer. It is absolutely critical to distinguish this from an arterial ulcer, because treating one like the other can lead to catastrophic results. A venous ulcer typically forms around the medial malleolus, that's the inside of the ankle. It's usually shallow, the surrounding limb feels warm, and crucially, normal foot pulses are present, because arterial blood is still getting down to the foot. An arterial ulcer, however, usually appears at the very endpoints of circulation, like the toes. It's deep, characterized by an excruciating lack of oxygen, and foot pulses are totally absent due to a blocked arterial supply. Getting this diagnosis right dictates entirely different surgical interventions. Moving deeper into vascular pathology, we encounter Buerger's disease, also known as thromboangiitis obliterans. This is a severe inflammatory disease of small and medium blood vessels in the arms and legs. But here is the absolutely essential takeaway: heavy smoking. Tobacco use uniquely causes these specific vessels to inflame, swell, and thrombose, or clot. This leads to profound ischemia, a dangerous lack of blood flow, causing severe pain even while resting, and eventually leading to tissue death, or gangrene. The critical medical intervention here isn't some magical pill or a complex bypass surgery. It is the complete and absolute cessation of smoking. That remains the only definitive, proven way to stop the disease from progressing to the point where an amputation is required.
Section 3. The Art of the Operation. Preparation and Patient Care.
Okay, let's explore how surgeons actually prepare for these complex operations and ensure patient safety. I absolutely love this next concept, Yogya Vidhi. Long before modern medical schools had expensive synthetic dummies or high-tech virtual reality simulators, this ancient practice of hands-on surgical training utilized experimental models. Trainings would relentlessly practice their incisions, excisions, and probing on gourds, watermelons, animal organs, and pieces of stretched leather. It builds critical muscle memory. It proves that the fundamental principle of perfecting hand-eye coordination offline to guarantee patient safety before ever touching a living human was formalized thousands of years ago. How cool is that?
And speaking of patient safety, remember the strict ancient requirement for rust-free, meticulously clean tools we discussed earlier? Today, that concept has evolved into rigorous scientific sterilization, the complete destruction of all microscopic life, including highly resilient bacterial spores. The gold standard in modern hospitals is the autoclave, which uses moist heat under intense pressure to reach 121 degrees Celsius, effectively destroying the proteins of any pathogen. We also use dry heat ovens, toxic chemicals like ethylene oxide gas for delicate plastics, and even gamma radiation for prepackaged disposable equipment. It's really just the highly technical, modern fulfillment of that exact same ancient safety mandate.
107. This is a very specific, very important number in surgical anatomy. It represents the total number of marma in the human body. In classical texts, marma means a highly vulnerable vital point where surgical injury or blunt trauma can cause massive, uncontrollable bleeding, loss of limb function, paralysis, or even death. Ancient surgeons mapped these zones meticulously to know exactly where not to cut.
Breaking down these 107 marma points reveals an incredible depth of ancient anatomical mapping. Out of the 107 points, 41 are located directly at vital blood vessels, 27 at key structural ligaments, 20 at major joints, 11 hidden deep in muscle tissue, and 8 situated at critical bone junctions. For a surgeon, mastering the location of these vital points during an incision is paramount. It maps perfectly to what modern surgeons refer to as safe zones and danger zones in anatomy, guiding safe dissection and preventing catastrophic intraoperative complications.
Finally, we look at Shatkriya Kala, the ancient framework outlining the 6 progressive stages of disease development. It begins subtly with the mere accumulation of a problem, moves to aggravation, then physically spreads through the body, localizes in a specific vulnerable tissue, manifests as a full recognizable clinical disease, and finally reaches the terminal stage of severe destructive complications. The entire philosophy here aligns flawlessly with modern preventative medicine. It emphasizes early diagnosis. Catch the disease at stage 1 or 2 and you can intervene medically. Wait until stage 5 or 6?
well, then you're forced into the complicated, high-risk surgical salvage operations we've discussed today.
Which brings us to our final thought. We've seen how blunt diantras became modern forceps, how the concept of meticulously cleaned tools evolved into pressurized autoclaves, and how practicing on fruits beautifully foreshadowed modern surgical simulation labs. It's a continuous, unbroken thread of human ingenuity dedicated to healing. So I'll leave you with this. If the medical wisdom categorized thousands of years ago still structurally guides the hands of surgeons today, what medical discoveries from our modern era do you think will endure to save lives 1,000 years from now? Thank you so much for exploring this fascinating historical and clinical journey with me. Keep learning and stay curious.